Hey, Taya.
Hello.
We're gonna do the quiz first, so we will be incommunicado for a bit. I will email you the quiz once I remember to do it.
Sounds good.
So just take it, email it back to me and should be fine.
Oh, but yeah, everyone. I just like was so done. I was like, exams are done. That all day. I was swallowing and I had my belt on. That's water. And then
You guys know,
they're everywhere. And then I'm gonna.
they're everywhere.
I know what it is. What is it? It's a slush.
Try to cup with this session.
I was going some sort of coffee, you know, they have like bring their own coffee.
All right, we'll take it over break on Wednesday. You guys know this slushies can come back.
Yeah, it's today.
It's today.
Yeah, we don't have one.
You guys really want slushy?
Yeah. Do we have scissors?
We can do an early break at 7:30 and go to work. We can come back.
Sweet, yes. We don't.
You're never back to it.
Yeah.
Then let's do it.
I'm gonna come from here.
It was there. No, it was Daddy.
I thought, why are we bringing them up?
Yes, it's wet.
Bring it, a mug and all. I brought one. You really bring it? Yeah.
Elena, where's Paige?
Run over that. Yeah.
So she won't be here.
So now
Okay.
Yeah.
Taya's out of town too. We're zooming. If she wants to zoom, she can.
I don't know if she talked to you.
Yeah, of course, I forgot. But yeah,
Yeah, I don't know what.
if she wants to zoom, that's, I don't think I posted the link on, I could post the link. too.
Yeah.
I can't find that recording.
So for, like, actually interact, but I will interact, so.
Right, okay. Will do.
I'm so.
Just send me the link. Otherwise it's. Well, we're gonna knock off one early for slushies, then let's get to the for.
Like,
This class that you hate so much.
Oh, it's.
I'm very sorry for what crazy. I'm just gonna apologize.
Me too, it's been a long week. Actually, I won't be on it. This was my girl.
Yes.
Like 13. Thank you.
All right, let's see. I'm gonna try and email you the quiz right now, Taya. We'll see if this works. If it doesn't, then we'll try after class. Okay. Okay, Taya, I sent you the file. Hopefully you'll get it soon.
Yeah, I got it.
Oh, marvelous. Okay. Technology is great when it works. And when it doesn't, you just want to scream. Right. Which organ systems only have most susceptible to damage? So they'll show the height like that. So when you say high, it's got to think most susceptible.
I'm not starting to make up. I did actually once, and it was.
Is anyone sending in a document besides the one that we made?
Thank you, is that everybody? Right. Okay, the first subject for today are medications to help quit smoking. Now, your first line medications include things to help you deal with the nicotine craving. So it includes the things like nicotine gums and sprays and patches and things like that. These sorts of things do cause people to quit at a higher rate than placebo. They do work. The amount of addiction that you have to nicotine after using these compared to placebo is higher, but it's acceptable as a treatment. So the other advantage of nicotine replacement treatments is that you can use them in combination with other treatments. So they have their place. So patches, for example, deliver nicotine continuously, but they take about 6 to 8 hours to achieve peak serum concentrations. They also deliver nicotine more slowly to the central nervous system than the other methods. Nasal spray is the fastest acting. Serum concentrations peak anywhere from 4 to 15 minutes when it comes to nasal sprays. Nasal sprays, however, may not be acceptable for someone with pulmonary disease, which is likely if they smoke for a long period of time. Probably the most widely used are the gums, the lozenges, and so on and so forth. Remember, nicotine undergoes a pretty extensive first pass metabolism. They're available over the counter for people over equal to over the age of 18. They're pretty reasonably priced, and they have their effectiveness, and you can combine them with other things. So the other drug is bupropion. This comes in the trade name, under the trade name Zyban. This is a different dose than what you see with the bupropion that's used as an antidepressant, Wellbutrin. This is a lower dose product. And then the other is varenicline. This is a one known by the trade name as Chantrix. Chantrix. There are second line treatments, but these are not FDA approved. And frankly, the evidence base for them is not very good. So it includes nortriptyline, clonidine, and that's it. So if you look at the first line treatments and you look at the 6-month quit rate versus placebo, as you look at those, I think you can see the quit rate is significantly higher than it is for placebo. So these treatments do work. There are some differences, but for all intents and purposes, the benefits of the medication are in general the same. If you combine drugs, it's clear that you get an increased effect. Also, it's clear that these drugs can be combined. They do tend to play well together. And you can combine, say, bupropion and the nicotine gums and something like that. So key points. Nicotine replacement with other first-line treatments, varenicline, bupropion. You can use them. You can use them in different combinations. You can also use them with psychotherapy. In fact, you should use them with psychotherapy. The big thing is usually patient preference and when it comes to which agent to use. And if you give up on pharmacotherapy before you actually quit, that might very well be counterproductive. So if someone starts a program, encourage them to stick with it. So let's look at a few pros and cons about nicotine gum. So this graph shows you the plasma nicotine concentration for the different products. You can see the patch kind of lags behind everybody else, like what I was telling you. You'll notice things like cigarettes really do the best at delivering nicotine. No big surprise there. But some of these others, like moist snuff and things like that, can give you delivery of nicotine that approximates that of cigarettes.
What's the lozenge?
Lozenge? Lozenge, it's like a cough drop. Yeah. In the literature, they might call this sometimes a troche, Troche, troche. A troche and a lozenge is the same thing. Some will say that they're manufacturing is slightly different. They're the same bloody thing. Just Troche, Troche, or Lawson, same thing. All right, so you can see that the cigarettes, as you see in the green bar, that goes up dramatically. On the left side, the moist snuff, that goes up pretty high as well. The rest of the lines represent the change in those nicotine levels based on the nicotine replacement therapy. This is to show that most of the nicotine replacement therapies have a pretty slow onset, but they do maintain sustained nicotine levels after you use them. Nicotine spray is the only one that really leads to a dramatic increase compared to others. So if someone needs a really rapid amount of nicotine in their system to manage a withdrawal craving, the spray is probably the most effective. The downside is that it may confer also a higher addiction risk. So the general idea is to try and maximize nicotine replacement options that provide sustained nicotine levels, like maybe the patch with gums or lozenges or something like that. So there are certain populations where the use of nicotine replacement should be done with some caution. This would include those with underlying cardiovascular disease, if they've had a recent heart attack within the last 2 weeks, or serious arrhythmias, or if they have serious or worsening angina. These individuals need to be cautious about the use of nicotine replacement treatments. Individuals under the use of 18 and women who are pregnant should also use nicotine replacement treatments with a good deal of caution. There are several advantages to nicotine replacement treatments. A patch gives you good, constant levels. It can be used, and the beauty of the patch is that it's nice, it's concealable. Gum, lozenges, sprays, they can titrate therapy to manage withdrawal and to manage cravings. Inhalers mimic the hand-to-mouth ritual that people get used to when it comes to smoking. And the kinetics of sprays and the rapid absorption can mimic what you get with a cigarette. The downsides are that when people use patches, they can have skin reactions to them. Also, the use of the patch is problematic because if you use it at night, it can lead to some pretty weird dreams. And one remedy is to take the patch off before you go to sleep. The problem is that the low nicotine levels in the morning may cause someone to really want that first cigarette in the morning. So if you take the patch off before you go to bed, that same person may really, really, really want a cigarette first thing in the morning. So try to keep the patch on as long as possible until it's tolerated. The gum may not be socially acceptable, and it may be really difficult if someone has dentures. It can cause the dentures, of course, to come unstuck and things like that. And there might be problems with inhalers if you have underlying lung disease and something like that, and the nasal spray can become more addictive. So when it comes to nicotine gum, you want to chew the gum slowly until you taste the kind of peppery taste or the tingling sensation. That means the medication is being nicely released. Then you park the gum between the cheek and gum. Try not to eat or drink at least 15 minutes before after using the gum. So you don't want to just chew it. You want to chew it until you get the taste and then park it, essentially. And once it fades, essentially repeat the process. You chew it, you release more, and then park it between the cheek and the gum. So the key points here is that nicotine replacement treatments are equally effective, except for inhalers, which provide a substantial increase in serum nicotine levels. Patches can be combined with gum and lozenges to manage cravings or high-risk situations. And be aware of the pros and cons, essentially, as you advise patients. So bupropion is a dopamine reuptake inhibitor. So it's different from most of the other antidepressants. Because it works with dopamine, it seems to work with the reward system. That's a system also responsible for cravings. So it reduces both nicotine withdrawal and cravings for tobacco. You can also combine bupropion with either nicotine replacement therapies or with varenicline. It works quite well with that, and you get increased efficacy if you do that. And with this medication, it's also very good if you have comorbid depression, since it has antidepressant activities. And it avoids weight gain. That's one of the beauties of bupropion. Side effects of bupropion: it can cause anxiety, bupropion has been known to cause insomnia. With bupropion, you also worry about seizures. This is more of a concern for people who have seizures. This should be taken into consideration, but at the dose at which you use bupropion for smoking cessation, lowering the seizure threshold is less of a worry than with the concentration you use for depression. So general recommendation is to use the medication once a day. The extended release is one you can use easily every 24 hours. The titration schedule is such that you want to start about a week before you want to quit. Get the concentration up. You start with a dose of about 150 milligrams. You increase to 300 mgs for about 3 days. For smoking cessation, you don't go over 450 milligrams a day. Most people do fine usually at about 450 a day. But many psychiatrists recommend only going up to 300 mgs a day. And so you can do that essentially 2 doses a day, 150 twice a day. Stephanie, was that a question or was that a stretch? That was a stretch. Okay. So key points: bupropion, very good evidence base for smoking cessation, is particularly good if you have comorbid depression. Useful for those concerned about weight gain, but you need to monitor anxiety and insomnia and do exercise caution in patients who are at risk for seizures. If you're not having seizures at low dose, it's usually not a worry, but you still might want to monitor the patient. So let's talk about varenicline. Varenicline is a partial agonist at the nicotinic acetylcholine receptor. So it acts like nicotine, but only partially activates that receptor. It will suppress cravings. It will tamp down withdrawal. So it acts a little bit like buprenorphine, that partial agonist at the mu receptor for opioids that can be used to help people quit. It will block other nicotine products from getting to that receptor. So it will help addiction in multiple ways. This is one of the reasons why you can use it with the nicotine replacement treatments. And it decreases the tendency for people to become addicted to nicotine on nicotine replacement treatments as well. Biggest advantage is that it can be combined with other medications. This is a very easy drug to dose. You dose it twice a day. There were considerable concerns about psychiatric adverse effects like psychosis and mania. So this led to the introduction of a black box warning. Since that time, there have been very large studies with about 8,000 people in those studies in 140 different centers in 16 different countries. All of these studies were randomized placebo-controlled trials. And in those studies, it was discovered that the psychiatric side effects of varenicline were overblown, were seriously overblown. So the drug appears to be very safe. Also, the rates of psychiatric effects of varenicline did not differ depending on whether or not the drug was combined with bupropion or with nicotine replacement therapy. So it has a low rate of psychiatric adverse effects. Drug is pretty well tolerated. Consequently, the FDA has removed the black box warning. So all that said, nausea can be an issue. In fact, nausea is fairly common. Up to about a third of patients will experience it. Other side effects include insomnia, oddball dreams, and then headaches, albeit headaches tend to go away. So like bupropion, you start dosing this a week before you want to quit. There is a starter pack that you can use before quitting, and then the regular prescription once you essentially say that's your quit date. Recommendation is to take the medication with food. That seems to decrease the nausea. Starter pack is a little bit unique. So for the first 3 days, you have a half a mg, followed by half a mg twice a day. And then you take 1 milligram twice a day. So you're ramping up the use of the drug. The starter pack then gives way to the so-called continuation pack, where you just take 1 milligram twice a day, usually morning, afternoon. Pretty easy drug to dose, essentially. What do you do if the patient is unable to quit after 3 months? The recommendation usually is to repeat for another 3 months. Research has shown folks who don't quit within the first 3 months, a good proportion of them will quit in that next 3 months. You usually want to try something else before resuming the varenicline. Failed attempts are actually more common than you wish they were. But as you stick with the medication, more and more people really start to quit. And if you combine varenicline with bupropion, the effect actually doubles. So you can combine these drugs, and they are more effective if you combine them. So key points. Partial nicotine agonist varenicline is, I sound like Yoda. Yes, varenicline. Partial agonist it is. It's easy to dose. It plays well with other therapies. You continue it for 12 weeks or up to 24 weeks, because so you can use it for 6 months. Doesn't seem to cause a lot of neuropsychiatric adverse effects, more frequently than any others. Now let's talk about e-cigarettes, because those are all the rage now. So the first generation e-cigarettes were a mess. You had inefficient nicotine delivery and you had a short charge time with a single volt battery. That gave way to the second generation e-cigarettes that had larger batteries and an adjustable voltage and refillable cartridges. So you didn't have to buy a whole new cigarette if you wanted to get another blast with the cigarette. You had more efficient nicotine delivery. And now the third generation ones are the advanced vaporizers, where the nicotine delivery matches that of conventional cigarettes. They're customizable, they're adjustable, and people who use them love them pretty much. The research on e-cigarettes is clear. E-cigarettes are healthier than regular cigarettes. That is clear. For this reason, in the UK, physicians will write prescriptions for e-cigarettes for smokers to help them quit. Case in point, when I lived in England from 1994 to 1997. 60% of the population smoked. If you went into a pub, it smelled like an upholstered ashtray. Now in Great Britain, about 20% of the population smoke. It's become less socially acceptable to smoke. You went into a restaurant, everybody was smoking. You didn't, you came out, your clothes smelled like cigarette smoke, it was awful. Now, smoking is not allowed in pubs, it's not allowed in restaurants. Big change for a culture that really liked their cigarettes. Now you go to some parts of Europe, they still smoke. Turkey, you go to Turkey, everybody smokes still. Japan, a lot of people smoke still. Although smoking in Japan has decreased pretty substantially. So e-cigarettes do help people quit. That's pretty clear. Are they a magic bullet? No. So here's essentially one randomized trial. Came out in the New England Journal of Medicine in 2019. Randomized 1,000 smokers to e-cigarettes or the nicotine replacement therapies. After a year, you had twice the abstinent rate in the e-cigarette group as you did with the nicotine replacement trial group. Well-controlled trial, they work. They seem to work. That said, there are concerns. Some people who do e-cigarettes do cigarettes and e-cigarettes, so they have increasing nicotine exposure. That's a problem. These cigarettes were meant to replace cigarettes, but some folks aren't using them for that. They're using them to supplement cigarettes. People are using them to smoke reefer. They're getting cartridges with THC and using them to smoke reefer and other stuff. So they're being abused. And data from the CDC has shown the rate of cigarette smoking in youth is declining, but the rate of e-cigarette use is accelerating. Studies have shown that lung injury can occur from e-cigarettes, but most of that data comes from people who use cartridges other than the nicotine cartridges. They'll use, THC or vitamin E or stuff like that. They're trying to do psychedelics. That stuff will burn your lungs and scar your lungs very bad. The amount of damage that you get from the e-cigarettes, if you use the approved cartridges, seems to be relatively minimal. But clearly using THC through these things is not good for your lungs. So the CDC has come out and just come out against vaping in general. And underage vaping is a concern. If you start vaping, will that now increase your risk of actually smoking? The data on that is not clear at this point. Some studies say yes, others say no. So I don't have a definitive answer for you on that one. This is a concern. So key points here. E-cigarettes, they're not risk-free, but they are safer than cigarettes, clearly. Vaping-related lung disease is a concern. If you have a patient who vapes, make sure they just use the approved cartridges with the device they're using. E-cigarettes seem to be a viable strategy for smoking cessation, and they're comparable with nicotine replacement therapies. All right. I am going to skip this, so we'll take our break now. You can go get slushies, and then we'll come back and do alcohol cessation. Okay? Go forth and put the sweet stuff. So Taya, in case you're wondering what all the fuss is about, so the student government has this announcement that says at 7:30, come to the Ralph Carey Forum. It's a secret surprise, bring your own mug. And Jetty apparently has inside information that it's slushies. And so I gave everyone license to go early and go get a slushie. That's what all the fuss is about. So you're obviously not here, so you can't get a slushie, but you can pop some popcorn or whatever. They'll be back and then we'll resume. So we're taking our break a little bit early.
I'm part of SGA, so I helped plan the super secret slushy surprise.
Oh,
So
you helped plan it.
yeah,
So you're the culprit. Okay, well, I'm sure students will be very grateful when they come back with their slushies.
glad they're getting them.
Yep, I will inform them that they should heap praise and thanks upon you. I am not getting a slushie, in case you're wondering.
Doing a lot better. Yeah, he's a lot more like mentally stable. Kind of figuring out his future plans right now. He went to the behavioral health facility, and then they basically like he had petition to stay there, and then afterwards he was yeah.
Yes.
Yeah, and then he was like he's like required to go to follow up to be that way, like they'll basically he'll be put back into a prison.
I understand. Another long mission understanding that you can't commit somebody on the basis that
Right, yeah. He's doing good right now. He's gone to all his follow-up stuff. Yeah, yeah. Good. Yeah.
Glad that we're still paying.
Fine.
You're not taking on water yet.
Yeah. I'm just trying to get an idea of like, obviously he had some time to get back on his feet, so like just figuring out. Yeah, no, there's not really a concern.
No. So my, I think that's one process of my brother, he's on the opposite spectrum. And, he, he's not older and I remember his song when he was physical. And I stood up, I was ready to walk even that I got this. But the risperidone he bought, it meant to actually put that it's low dose.
Yeah.
Very low dose. But it does help. And what's not that deep. And I was chatting with someone on Twitter last night. The lady was really paying attention about the classification. Our soul uses our brain to direct our body. The brain doesn't work right. Body's not right. And getting the brain right sometimes just needs one to help.
Right. Yeah, I agree.
She didn't have a lot to say, but I was I realize that psychiatric medicine is not like cardiology. Oh, look, you had a heart attack. It's
Right.
there's more subjectivity, but they do use objective instruments in psychiatry, and it's not, and there are studies that do look at physical differences of patients, but the measurements are based on how you feel, it's looks like something. It's just kind of the subjectivity is kind of
Right. Yeah, I was a one-on-one with mental health patient in the ER a couple shifts ago, and he had gotten off of all of his meds, and they ran a screening on him, and he should have been positive for like if he had been taking his meds at the place he was at, he should have been positive, and he wasn't. So he's basically like I don't know, like withdrawing, but also like he's not on them, so like his mood swings were crazy, and like he was super violent and just like angry and laughing, and then like he had just a ton going on. He was also hallucinating. Well, so that happened to my other one-on-one. We had to have the police come and hold him down so he could get injection, but this guy, yeah, he would like eat whatever you put in front of him, so they chopped up some tablets and put them in his pudding or applesauce, and he ate it, and then like he fell asleep, which is good, but the second he would wake up, he would just stare at me like all this stuff, and like, oh, as long as you stay there, I'm fine, say all you want. No. He charged at me twice, and I had to like roll my chair in front of him. And at that point, the doctor who was in the ER, he's like a big guy, so he would come and be like, get back in bed. Like, but he was kind of scary. I didn't know what to do with him. And I talked to my supervisor, and he ended up, like, they upped his dosage quite a bit, and sadly, kind of snowed him in a way, but he was being very violent and aggressive with people. Yeah. Yeah, my life has just been full of a lot of mental health stuff. So
you're kind of a flow.
yeah, I work in like med-surg, ER, and ICU.
So this was side ER.
It was just regular ER.
Right, on the side.
We had no placement for him, so it's like patient area. Yeah, we were waiting for Likewise to kind of interview with him and see where he needed to go, but they were taking forever, so he was there for a few days.
Can you, because there is a site word there.
Yeah. we
Can you
did.
amend them?
So- The issue with the site floor is it's basically like they're picky. We'll, they are. We'll like have a patient who should really go to the site floor because we just aren't equipped on our floor to take care of them. And they won't take them because they know they're like a complete handful and they have like a full floor. So they exactly. It's a big issue at the hospital right now. We have like nowhere to put these people, and so they stay on med surg or in the ER for days, and it's not a great environment for them. And then they have one-on-ones, and then it's an issue of like safety for the one-on-ones. I mean, like I've had people who had to be put in like vital restraints, and then in that case, like everything's taken out of the room, and I have to sit with them. But when they're restrained, it's different than like someone who can just like charge at you from out of nowhere. I don't know why people keep restraining. It's kind of confusing. I don't know what they're doing. Normally, if they come onto the med surg floor and they're by restrained. Unfortunately.
Part of me wants to just start and. I wonder if they have to wait in line.
Probably.
Maybe this wasn't such a good idea. Well. I think maybe should just start. Because time is flowing away. All right, then next on the agenda is medications for alcohol abuse. So in the old alcohol abuse disorder classification, there were two different diagnoses: alcohol abuse and alcohol dependence. That was DSM-4. DSM-5 did away with those and just has one designation: alcohol use disorder. And you can have mild alcohol use disorder, moderate or severe alcohol use disorder, depending on how many of the criteria you meet. That's easier. So the simplification of the diagnosis, I think, was pretty useful. There's a condition called at-risk drinking. And this is not alcohol use disorder. So if you, for example, you binge drink, and the definition of binge drinking is pretty careful. It's 5 or more drinks for a man, 4 or more drinks for a woman in one sitting, which is a lot of drinks. Of course, it depends on what kind of drink it is, what the alcohol content of it is. If it's whiskey, that's one thing, as opposed to if it's, ginger beer or something like that. So at-risk drinking means that you consume that much alcohol in a short period of time and you get pretty soused. So if someone has this at-risk drinking behavior, they're at risk for alcohol use disorder. But essentially, a 10-minute conversation is usually enough to change their behavior. They don't need, AA meetings. They don't need medication or something like that. You can usually get folks like this to change their behavior with a conversation. So at-risk drinking can escalate to alcohol use disorder. There's something called inherited drinking disorders. This sounds like somebody has, this gene and that gene causes them to have a drinking disorder. No. It just means that it takes a lot for you to get drunk. That's really all it means. And people who have this condition where it takes a lot for you to get drunk, because they're drinking so much and because they think that it doesn't affect them, they're actually at a higher risk for a more severe type of alcohol use disorder. Now, I have to say this kind of runs in my family because the people in my family, our livers work in such a way that people in my family can drink a whole lot before it seems to affect us. So having seen that in my family, that's the case. Social drinking pressure. If you go out with friends and they like to drink and they really want you to drink, so they make you feel like you're part of the crew, that can also lead to alcohol use disorder. So there's more than one way for people to become addicted to alcohol. So there's 3 drugs for the treatment of alcohol use disorder: naltrexone, acamprosate, and disulfiram. Of these 2, naltrexone and acamprosate are the most commonly used. So disulfiram is a tablet that you take, and it uses the same enzymes in the liver that the liver would use to process alcohol. So if you're drinking alcohol and you have disulfiram in your system, the disulfiram doesn't get processed and it makes you puke a whole bunch. So it makes you sick to your stomach if you take alcohol with it. Now, the problem with this drug is people who take it, oh, I want to drink, so I'm just not going to take the disulfiram. So this usually only works for really motivated people who really want to quit and have a plan for quitting. They just need this kind of as a safety blanket. That population is a pretty small percentage of those who have alcohol use who are afflicted with alcohol use disorder. So the majority of patients are treated with either naltrexone or acamprosate. So which do you pick? Naltrexone or acamprosate? It depends on the patient's preference. So acamprosate is 2 pills 3 times a day. Naltrexone is 1 pill once a day. Well, if you want ease, which one are you going to pick? Naltrexone. It's easier dosing. Some patients may not mind taking 2 pills 3 times a day. It's really going to depend on what the patient wants. So essentially, set it up with the patient and say, here are the options. Which one do you want? So naltrexone affects heavy drinking days. When you drink heavily, you have withdrawals. Those withdrawals make you feel worse, so you drink essentially to get out of the withdrawals. Naltrexone is an opioid antagonist, so it interrupts the subjective effects of alcohol such that if you have 1 drink, it's a lot easier to say no to the second drink. So it reduces the likelihood of heavy drinking. It also reduces cravings, and it's able to overall sustain abstinence in people with alcohol use disorder. Acamprosate doesn't have a big impact on reducing heavy drinking days like naltrexone does. Instead, it will sustain the abstinence periods because it reduces cravings overall and it reduces the likelihood of relapsing. So it reduces the likelihood of, quote unquote, falling off the wagon. So if someone has cirrhosis, you can't use naltrexone, but you can use acamprosate. Acamprosate, perfectly fine if someone has a liver disorder. The drug doesn't undergo that much liver processing at all. But if someone has kidney problems, acamprosate is excreted by the kidney, even though it's not processed very much by the liver. So if someone has kidney issues, You can't use a compressate, but you can use naltrexone just fine. So those are other considerations. And if someone's on opioids, you can't be on naltrexone because naltrexone won't prevent the opioids from working. In that case, you'd want to use the compressate. So those are other issues as well. These drugs were never meant to be used in the absence of counseling. A good deal of research shows if you use them without counseling, they don't work as well. And we could say that about antidepressants as well. They're meant to be used with counseling. So social networks and counseling, very, very important. And those are the drugs for alcohol use disorder. Are there any questions about those three drugs? Disulfiram, compressate, naltrexone, Jennifer?
Why would they be processed in the liver after drinking and just the liver? Would they like try and make it like a listen to this?
Alcohol is not processed by cytochrome P450 so much. It's processed by cytochrome P450 independent phase 1 reactions. It's usually alcohol and aldehyde dehydrogenase are the enzymes that process it. Converts it to acetaldehyde. Acetaldehyde is the metabolite that does most of the damage. Crosses blood-brain barrier, causes neurons to swell, and causes you to have the issues. So that's why essentially, if you've been drinking a while and you have fatty liver disease, you have cirrhosis, then a compressate is a better choice because naltrexone, its concentrations might soar if your liver doesn't work very well. All right, so those are the drugs for cessation of smoking, cessation of alcohol use. And now we get into muscle relaxants. This is a difficult group to talk about because the clinical evidence for the efficacy of muscle relaxants is lousy. So they are prescribed, they are used, but they don't necessarily work all that well. Now, there are people who have spastic conditions, like multiple sclerosis or something like that. You get these horrible spasticities. Muscle relaxants are very good for that. But people say who have back pain or musculoskeletal injuries or something like that, plenty of people swear by muscle relaxants, but there just isn't a good evidence base for their use. Having said that, physicians will still prescribe them. So if a muscle is damaged by overstretching or overuse or something like that, if you have a joint that's damaged, you have tendon tearing, something like that, the injured area is going to provide a lot of sensory impulses to the spinal cord, and the spinal cord might, in response to that very intense sensory input, cause the muscle to rhythmically contract in a spasmodic fashion. As the muscle contracts very powerfully, it will also try to start to accumulate lactic acid. And because the muscle is contracting, that will prevent the muscle from being able to drain itself of the lactic acid. So the lactic acid builds up in the muscle, and that essentially causes this cycle of damage to the muscle, increased lactic acid, increased spasm, increased lactic acid production, decreased drainage of the lactic acid, more spasm, so on and so forth. And it's really a vicious cycle. And those of you who have had bad muscle injuries can probably attest to this. It bloody hurts. And it keeps hurting. And you try to sleep and you can't because your muscles are just kind of going at it. And you really need to sleep to repair the damage, and you can't because it hurts so darn much. And can I get an amen? Someone out there? Yes, thank you. So the muscle relaxants are meant essentially to interfere with the neural impulses to the muscle, so that the muscle essentially will stop contracting. You can drain the lactate out. You'll stop the fasciculating spasms, and then the muscle can just get down to healing. That's the theory, at least, behind muscle relaxants. So they will tend to work in the central nervous system. There are a couple that work in the muscle. The big one is dantrolene that will work in the muscle, but most of these will work in the central nervous system. So the centrally acting muscle relaxants include baclofen, carisoprodol, cyclobenzaprine. You might want to put a little star by cyclobenzaprine because that's probably the one that gets used the most out of this list. Clozoxazone and then methylcarbamol. And then these two, orphenadrine and tizanidine. Tizanidine is really useful because it has a short half-life. The beauty of tizanidine, you can take it when you go to bed and you got that injury and that injury is going to keep you up. Tizanidine will knock you out. So you should never take this drug during the day. I had a student once who had a really bad injury, and the doctor prescribed him that. He was taking it during the day because his muscles are spasming, his back started to spasm, and in class, he was back there, just slept like a baby throughout class. And I remember watching him just going, yeah, sleep it off, pal, go ahead. At least he came to class, but that drug will really knock you out. That's another issue with these drugs because they tend to be immunosuppressive, they are sedating. So driving while taking them is a big X-nay on the driving aid, and also making any sort of important decisions, signing important documents, anything like that, you don't want to do while you're on these medications. So the direct muscle acting relaxants include Botox, dantrolene, and then the incobotulinum toxin A. That particular medication is a modified snake toxin that relaxes your muscles. Those are given usually by injection straight into the muscle, but dantrolene comes in an oral form. Now, when it comes to the mechanism of how these work, they're all over the place. So there's no one mechanism by which these work. By the way, what flavors were the slushies?
Oh, pumpkin, blue raspberry, but the blue raspberry.
Oh.
It was nice.
Sounds good.
It was
Okay. Taya's on Zoom. Taya, by the way, was one of the people who designed it and planned it and what have you. So you can thank her. When I told her where the class is going, she said, "Oh, I was involved with planning that." So make sure you thank her. So baclofen is a GABA receptor agonist. By activating GABA receptors, you increase the activity of inhibitory interneurons. Those inhibitory interneurons then essentially shut down motor neurons that tell the muscle to contract. Cyclobenzaprine is a serotonin receptor antagonist. Serotonin receptor antagonists are important for the transition of the signal from the motor cortex to tell the muscle to contract. And so it works in the spinal cord to tell the muscle don't contract. Dantrolene has several different ways of reacting, but it tends to prevent the release of calcium, it binds to that ryanodine receptor and blocks the endogenous ligand from binding to it and causing release of calcium stores. And then diazepam Valium is a benzodiazepine, so it's also a GABA receptor agonist. So this picture here is meant essentially to show you how these work. Here's your motor neuron. You have activational neurons, you have inhibitory neurons, and you can see that the benzos like Valium or like baclofen are going to work on this inhibitory side. Baclofen also has an inhibitory activity on the glutaminergic neuron as well. Dantrolene is going to work essentially in the muscle, and then cyclobenzaprine is going to prevent the signal from ever getting to this receptor here. So these are meant for relieving the pain associated with musculoskeletal injuries. It's meant to be used with rest and physical therapy and stretching and other things like that. They're also very good for relieving spasticity. And they may be of use in spinal injuries, spinal cord diseases, and other things like that. What about with kids? Kids with cerebral palsy, they can have spasticity. Baclofen does a very good job of relieving that. If kids are older than 12 and they sustain an injury that causes spasm, you can use metaxalone. If a child develops tetanus, the drug of choice is methylcarbamol. That has a particular efficacy for tetanus. The other muscle relaxants are safe in children, but you have to respect the dosing. The dosing is different in children. With adults, the drugs can cause drowsiness, confusion. If you have muscle spasms related to anxiety, diazepam is your choice because it's also an anti-anxiolytic. Pregnant, lactating women should not take these drugs. They're not safe for the fetus. They are excreted into breast milk, and they cause the baby to become drunk and flaccid. So, not to be used under those conditions. Older adults are more likely to experience neuropsychiatric effects with these drugs. Consequently, for older adults, Crisoprodol seems to be the best drug for older adults. Contraindications, cautions, allergies to these drugs. Not common, but it has been reported. First dose, if they show the signs of allergies, they show hives, bronchoconstriction, stuff like that, pull the drug right away and administer Benadryl or something like that. There's no demonstrated benefit if there are spasms caused by rheumatoid arthritis. Don't use them then. They can exacerbate seizure disorders in a patient with seizures. Now, the sports medicine guy at Fort Allegiance told me if you dose them properly, you can use them in people with history of epilepsy. So some people will use them under those conditions, just at lower dose, others won't. There's a debate on that one, but you definitely have to use them with caution in people with epilepsy. Cardiac function can be depressed, so if you have a patient, say, with heart failure, use them with caution. You probably have to dose the patient down. And then monitor that heart like a hawk. If they have a condition characterized by muscle weakness, these drugs will make the muscle weakness worse. Hepatic or renal dysfunction can disrupt the metabolism of these drugs. Dose down as needed. And with baclofen, if you have spasticity that contributes to locomotory function. If you block the spasticity, you'll also block the locomotor function. So that's an issue with baclofen. So keep that under consideration. So adverse effects, drowsiness, fatigue, weakness, confusion, headache, insomnia, so on and so forth. The confusion, headache, insomnia, that's more common in older people, not so much in younger people. Hypotension can be an issue, especially if they're already on blood pressure medicine. Arrhythmias. It tends to be the case that they make existing arrhythmias worse, creating new arrhythmias. That's more the case if you have a patient with compromised renal function and the drug builds up in concentration. They do, however, in some cases cause dry mouth. That's pretty common. Anorexia, constipation, nausea. Urinary frequency. Enuresis, that means bedwetting. Urinary urgency, that's actually relatively common. It's worse in older people than in younger people. Chlorzoxazone turns the urine a purple-red color. So if that's prescribed to a patient, you get this freak out phone call. I'm bleeding to death. I've got bladder cancer, something like that. Tell them it's the drug. Better yet, warn them that this is going to happen. It's completely normal. That also means, since this might cause some incontinence, it might stain their undergarments. So you might recommend a panty liner or something like that. Tizanidine has been associated with liver toxicity. If you dose it right, that's not very common, but it's been reported. Baclofen, you have to taper the drug. You don't stop baclofen cold turkey. If you do, people will start to get hallucinations and stuff like that. It's not pretty. Let's look at DDIs. If you take these drugs with alcohol, it will increase CNS depression. So no alcohol when you're taking these drugs. Now, a student asked me one year, can a patient say, have a drink in the morning and then take the drug at night? Sure. If you're having a drink in the morning, seems to me you might want to join AA. People normally drink at night, and then you're going to take these drugs typically at night. So that kind of defeats the purpose, it seems to me. So I'm just going to play it safe and say no. All right, what's your job when people are on these drugs? So you want to assess for known contraindications. Does this patient with their medical history have renal problems, liver problems? That means the drug has to be dosed down. Are they an alcoholic? Are they taking other things that can suppress the CNS, things like that? So the physical exam, that's your job. Monitor liver and renal function to detect adverse effects. That's also your job. So you want to, with the diagnosis, you want to determine if the CNS effects are going to increase the risk for injury. Is this person a falling risk? If they're falling risk, muscle relaxants are going to make them even bigger falling risk. If the drugs upset their stomach, do they already have a sour stomach because of maybe some condition they have, their diet, other medications they're on? Are their thought processes going to be disturbed because of these drugs? And if the patient already maybe has dementia, it'll make the dementia a lot worse. Those are things to consider. So you're going to educate the patient. You provide safety measures, adequate lighting, raised side rails, places to grab if they're unsteady. If the patient can't tolerate the drug side effects, then provide measures essentially to tolerate the side effects. The patient, for example, has an incontinence because of the drugs, recommend Depends or something like that, short term. Monitor respiratory status, discontinue the drug, any sign of liver renal dysfunction, provide additional spasm, pain relief, rest periods, heat application, blah, 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 things like that. And then you evaluate, does the drug work? Look for improvement of pain and spasm. Monitor for adverse effects. Are you getting, is the cost benefit analysis in the favor of the benefits? If it's not, let's not use the drug, let's discontinue it. Evaluate if your patient understands the education you've given them. How do you do that?
Find out that you told them.
Right. Catherine's absolutely right. You have them repeat back what you told them and you ask them questions. And you ask them questions. So what happens if such and such happens? What happens if you think you're gonna fall? What happens if your blood turns bright, your urine turns bright red, something like that? What happens if? Do some kind of play acting scenarios or something like, what will you do if? So on and so forth. And then monitor patient compliance to make sure they're taking the medication as needed. Any questions about the centrally acting muscle relaxants? Let's go to the direct acting muscle relaxants. So the safety and effectiveness of these has not been established in children, at least for Botox and the oleclavotoxin. Dantrolene is used to treat upper motor spasticity in children, but the dose has to be adjusted for kids. Children are at increased risk for GI and CNS toxicity with dantrolene. Keep that in mind. Once again, pregnant lactating women can't use. Avoid activities that require alertness or deep decision-making or something like that. Premenopausal women are at increased risk of hepatotoxicity when it comes to the use of dantrolene. So if they're on other drugs that tax the liver, like, for example, birth control, oral birth control, those are things to consider. Older adults more likely to experience adverse effects. Older women receiving hormone replacement therapy are at the same risk of hepatotoxicity as premenopausal women in association with the use of dantrolene. Contraindications, allergies, of course. Spasticity that contributes to locomotion, because these treatments will decrease the spasticity. They will also affect locomotion. Active hepatic disease, use with great caution or don't use at all. Pregnancy and lactation, don't use at all. Women older than 35, increased risk of potentially fatal hepatocellular disease. History of liver disease or previous dysfunction increases the liver susceptibility to cellular toxicity with dantrolene. Respiratory depression is exacerbated by these drugs, And cardiac disease with these drugs can be a risk factor. So use with great caution or don't use at all. Adverse effects. GI irritation, urinary frequency, bedwetting, things like that. Adverse effects are pretty similar with the centrals, as you can see. Dantrolene, of course, the big issue is the liver. So with dantrolene, watch the liver. In fact, I had a student one year, she drew a liver. She was good at drawing livers. I'm not. My livers look like triangles. She drew a liver and wrote dantrolene in the middle of it to remind her with dantrolene, you must watch liver function. Botulinum toxins have a higher than average incidence of allergies. Some people, before they use botulinum toxin, will actually skin test the patient. Might be a good idea. Estrogens increase the risk of liver damage with dantrolene. The central acting muscle relaxants, they interact with other drugs that can block the neuromuscular junction. So that includes aminoglycosides, lincosamides, that includes the antibiotic clindamycin, quinidine, an antiarrhythmic, mag sulfate, anticholinesterases that are used for dementia, succinylcholine, that is a paralytic, polymyxin, another antibiotic. These have additive effects with the central acting muscle relaxants. So don't use these drugs together. All right, what are your jobs? So assess for contraindications. If there are contraindications, warn the provider. Conduct a thorough assessment per your job as the nurse. So any acute pain related to GI and CNS effects, those can be affected by the drugs. You also want to look for disturbed thought processes related to the drugs and the risk for injury related to the CNS effects. Dantrolene, periodically discontinue it for 2 to 4 days as ordered to monitor therapeutic effectiveness. At the first sign of liver dysfunction, pull the drug. Just pull it. Safety measures, like we said before, educate the patient, as we said before. The injection site for botulinum toxin, make sure you check the area for active infections. Botulinum toxin can cause some issues when you're at the injection site. Dantrolene 2, if it's given intravenously, the drug is pretty alkaline, so it irritates tissues. So make sure you're watching the site. If there's irritation, provide a bandage or something like that. Monitor for adverse side effects and monitor compliance and so on and so forth. And then, does it work? Does it work? Okay, a little practice quiz. See what you learned. All the following are direct acting skeletal muscle relaxants except botulinum toxin type A, myoblock, or dantrium, or none of the above. Who thinks A is the right answer? Who thinks B is the right answer? Who thinks C is the right answer? Who thinks D is the right answer? Correct answer is D. All three of those are direct skeletal muscle acting relaxants. Not central acting, but direct. All three of those are direct. Which of the following is the priority nursing intervention for children receiving muscle relaxants? Is it A, assess bowel sounds and activity? Is it B, provide skin care? Is it C, administer the drug with food, or is it A and B? Who thinks it's A? Who thinks it's B? Who thinks it's C? Who thinks it's D? The answer is A, because children are especially at increased risk of central nervous system and GI toxicity. So that's why A is the most important thing that you need to monitor as the nurse. Question 3, what is the centrally acting muscle relaxant of choice for children with tetanus? Is it A, botulinum toxin type B? Is it B, dantrium, which is the trade name for dantrolene? Is it C, baclofen? Or is it D, methylcarbamol? Who thinks it's A? Who thinks it's B? Who thinks it's C? Who thinks it's D? The answer is D. The answer is D. Baclofen is indicated for children with spasticity who have cerebral palsy. Question 4. How long should baclofen be tapered to prevent the development of psychosis and hallucinations? 12 to 21 days, 1 to 10 days, 7 to 14 days, or 7 to 21 days? Who thinks it's A? Who thinks it's B? Who thinks it's C? Who thinks it's D? The answer is C. C. Question 5. A patient who had a dose of botulinum toxin type A complained about headache and dizziness. What's the most appropriate nursing response in this case? Provide comfort measures, institute safety measures, assess possible anaphylactic reactions, both A and B. Who says A? Who says B? Who says C? Who says D? The answer is C. Those particular symptoms are signs of an anaphylactic response. So assess for possible anaphylactic reactions. All right. Are there any questions about the muscle relaxants? Sorry? Back with them. All right, so we got the 3 of those. Let me look at what comes next really fast. I can't remember what comes next. Oh, mercy, it's the wrong class. Okay, we've got, I think paralytics are next. Paralytics are next, then anti-Parkinson's drugs, and then MS drugs for MS.
Go spring break, baby.
After spring break. Enjoy spring break. You'll have a quiz, and I'll make it due for the whole of spring break.
Wow. Oh. I need a good nap.
All right, Taya, have a great spring break. Come back refreshed and enjoy yourself.
Thank you.
Good night.
You're good.